Hello, welcome to the board exams. In preparation for your dental exam, we're going to discuss part two of dental occlusion and related structures. Okay. All right. So if you haven't reviewed the part one of this lecture, make sure you review part one so that this part two can make sense. Okay. All right. So what's a centric relation? We mentioned it in lecture part one of this series that centric relation is a bone-to-bone relationship. Okay. So this is when the condyles are in their most superior anterior position at the articular eminences with the discs properly interposed. Okay, so you can see here in the picture that this is the articular eminence. Okay, you can see the disc, and this is so the anterior portion of the articular eminence is here, and this is the posterior portion. Okay, and so it is the most superior anterior position of the condyle. Make sure you remember that. Okay, centric relation. So centric occlusion has been described as a tooth-to-tooth relationship. All right, remember, centric relation is bone to bone relationship. Centric occlusion is a tooth-to-tooth relationship. And so you have to know that if they ask you centric occlusion versus centric relation, you have to know that one of them is a tooth-to-tooth and the other one is a bone-to-bone. Nice self-explanatory here. Okay, so when the condyle is moves anteriorly or posteriorly from CR, so CR is the most anterior. Okay, most anterior and superior. So this is most superior and anterior. When it moves from the most superior anterior, it has to move inferiorly. Okay, it has to move down like this. Okay, moving from the CR position, the condyle must move inferiorly. The anterior teeth and the mesial inclined planes of the maxillary posterior teeth should guide the condyle back into sitting position. Okay, if you want to unseat the condyles, then the condyle must move inferiorly. All right, so the holding planes, what are the holding planes? The holding planes, so you have the mesial inclined planes of the upper teeth. Okay, these are the holding planes. And if the mandible is closed in a retrusive position, these holding planes will bring the teeth to centric occlusion. That's the function of the holding planes. Okay, is to bring these to bring the teeth back into centric occlusion. Okay, these planes are also important for proprioception purposes. So you have to know proprioception, meaning knowing what is in between your teeth. So that's going to help due to the holding planes. So when you're adjusting the occlusion on a restoration, then you don't have to ask the patient to grind around. Otherwise, what happens is you may adjust some areas that do not need to be adjusted. Okay, because the articulating paper that you use may mark the holding planes as areas of interferences. So don't ask the patient to grind and in all directions. Okay, just ask them to open and close, and what you say is tap tap. If you tell them to tap tap, they're going to open and close without grinding. Okay, so border movement. I think we touched on the border movement earlier. Okay, so we touched on the Bennett movement in the part one, and so here we're going to talk about border movements. All right, and we're going to talk about the Posset's envelope of movement, and so make sure you keep an open mind. All right, and make sure you memorize the principles. So border movements occur in frontal plane, mid-sagittal plane, and the horizontal plane. So they occur in 3 planes. Okay, frontal, mid-sagittal, and horizontal. All right. So the Posset diagram represents border movements in the mid-sagittal plane. So this is the Posset's diagram. Okay. And this is the one which represents the border movement, okay, in a sagittal plane. Okay, so this is how the mandible moves from translation to rotation movement in the mid sagittal. So meaning in a profile view, but right in the middle of the teeth, in the middle of the incisors. Okay, that's a mid sagittal plane. So it's an anterior posterior direction. So what is the highest point on the Posset's triangle? So the highest point is the centric occlusion. Okay, this is the highest point on the triangle, Posset's triangle. So centric occlusion is the highest point, and the lowest point on the Posset's diagram is maximum opening. Okay, so you have initial opening here, and you have translation opening here. Okay, so the last point here is the maximum opening, and the phase, okay, B to CR. So from B to CR, or from CR to B, when you move from CR, okay, remember CR is the most superior anterior position of the conda. When the mandible is moving from CR, it moves inferiorly first. So this is called the hinge phase of opening. Okay, hinge phase of opening is also called rotation. Okay, rotation opening. So this is equal to hinge. Rotation and hinge, the same. Okay. And the most anterior point in the diagram is the maximum protrusion. If you ask someone to protrude, they're going to, okay, they're going to go to F here. So F is the most, is the maximum protrusion. All right. Okay, so rotation, which is hinge. Okay, so in the initial phase of opening from the centric relation, the condyle hinges or rotates about a fixed axis. All right, and this axis runs through each condyle, and it is called the hinge axis. Okay, so hinge axis is more of a rotation. So the hinge axis can be determined and recorded for diagnostic and restorative purposes. Okay. So a hinge opening is represented by the from CR to B on a posterior triangle. And so as you can see from CR to B here, from CR to B, that's the hinge opening. Okay, the initial phase of opening. Now, so the still on the rotation, which is hinge. So you have the first 25, okay, about the first 20 to 25 millimeters from centric relation opening. That's hinge opening. Okay, the first 20 to 25 millimeters. Okay, which is this one here. This is hinge opening. All right. And then after when you open more, and then you have B to E, that's translation opening. All right, and then you have more opening of the mouth. Okay, translation opening because the condyle is translating from CR down the articular eminence posterior slope. Okay, leading to opening. So during translatory opening, then the condyles translate or slide down and forward. So down. So translation, you have condyles moving down and forward on the articular eminence. And the maximum opening may slide over the crest of the articular eminence. Okay, and if that happens, sometimes it may cause like open lock jaw. Okay, because sometimes the condyles don't go back into the fossa, so you have to actually reduce it. So translatory opening is represented by the line BE, as I mentioned earlier, and the translation of the condyle normally continues until there's about 40 millimeters, 40 to 60 millimeters, okay, of total opening. This sometimes you can measure, and there's the way you can measure. I know that 3 of my fingers vertically aligned, that's about 46 millimeters. So if somebody is able to open 3 of my fingers, okay, meaning of course you have to put gloves on to measure it, that means they have normal opening. Okay, so the hinge, the first, so the again posterior triangle, what is presented by the line CR to B, that's the hinge opening. Okay, and B to E, that's translatory opening. CR to B, that's about 20 to 25 millimeters, and then the B to E, that's about 40 millimeters. Okay, all right. So as you can see here, hinge opening. Okay, the initial ones from CR. Okay, this is the hinge opening. So the diagram represents the movement of the mandibular incisor edges in the mid-sagittal plane, and the diagram here does not always apply to the mechanics of the TMJ, so it may vary a lot. All right, so you have to keep in mind that so this the CR to CO slide when the patient moves from CR to CO slide, okay, CR to, what is a CR to CO slide? This is misleading. So, but you can be in CR whereby almost your lips, the lips of the patient are not touching, and then when you go to CO, which is centric occlusion, meaning, remember we said that sometimes you can use maximum intercalcification, then you have the decrease in the interarch distance. Okay. Centric relation pivot. So the centric relation interference may act as a pivot, and they may distract a conda. Distract meaning it may cause the conda to come out of the fossa. So in centric occlusion, the conda is in posterior and inferior position. All right. So that's very significant. As you have to know this, because in centric relation, the conda is in the most superior anterior position. In the centric occlusion, then so now you have in the centric occlusion you have the conda, which is in the posterior and inferior position. Okay, so the Gothic arch tracing, it's Gothic. Okay, so make sure you look at it, memorize it. Okay, it's good to know. Make sure you keep that in mind. So the Gothic arch tracing is also known as Jesus tracing, and it depicts, okay, it shows border movement in the horizontal plane. So posset triangle. So posset has two S's. That's sagittal plane. And then you have the Gothic arch. Okay, this is horizontal plane. And so the Gothic arch tracing has been likened to the cross foot, and the apex of the cross foot is centric relation. Okay, so centric relation is the apex of the cross foot in the Gothic arch tracing. Make sure you keep that in mind. Okay. All right, so this is a cross foot on the Gothic arch tracing, and all right, so the blue here, the blue here represents. Remember, when we say the line, so you have to identify the cross foot is on the maxillary teeth. Is this right or left maxillary arch? That is the right side. Okay. So the blue, this blue here is pointing to the is pointing to the non-supporting clasp. So that's a working movement. Okay. And the yellow is also pointing on non-supporting clasp. Okay. So this means it's a lateral intrusive movement for the yellow. Okay, so blue here is going to be working, and yellow is going to be lateral protrusive, and the black one here is, and you have the maxillary arch shown, so, and the arrow is moving forward, so it means the mandible moves forward. So this is a protrusive movement. Okay, and the green is pointing to the working, to the supporting cast. So this is a non-working. Okay, so the principles that we discussed in the previous lecture, now you can see that how they apply in this way. Okay, so on the lower it's the same thing, except that the black arrow here, which is shows like it's a retrusion. Okay, so the black arrow here is going to it shows um, protrusion. Okay, because the arrow shows that it's in the on the lower, it's moving back, but remember it's on the arrow is drawn on the mandible, so it means it's in the actual opposite side, so it's moving to the front. So this is a protrusive. The black arrow represents protrusive movement. All right, so the border movement is frontal plane. So remember, the envelope of motion. So there you can consider three planes. You have the mid sagittal, the frontal, and also you have the horizontal. Okay. So the outer line represents border movements for the lateral excursion and opening. The outer line is this one here. Okay. That's the outer line. The inner eye drop, make sure you know that. The inner eye drop represents masticatory cycle. So when you're chewing, that's how your mandible moves. It looks like it's moving a little bit to the right and then downward and then up, and you complete the cycle. But it's an interesting shape. It's a teardrop shape that forms. Okay. Okay, so forces of occlusion. So occlusal forces should be borne along the long axis of the teeth. The occlusal contacts on inclines are not desirable. So if you want to establish a nice crown, which its forces are nicely well distributed, then you have to have occlusal forces which are directed along the long axis of the tooth. Okay, this promotes, if everything is healthy, this promotes stability of the occlusion. Okay. So the primary occlusal trauma. Primary occlusal trauma. So it's the number one sign of occlusal traumatism is mobility. Okay. When you know there's occlusal trauma, they're gonna have some mobility of the teeth. And fremitas, as we mentioned in the previous lecture, this is functional mobility. And this is functional mobility could be due to a lot of factors, but mostly it's from the clenching, okay, excessive forces on the tooth. Which ends up causing primary occlusal trauma. The primary occlusal traumatism is defined as normal forces on normal supporting structures. And when the prematurities and interferences are removed, then the tooth can be stabilized for several days. Okay, so you can see the center of gravity here of the tooth, and then you can see how much the forces are nicely balanced in this case. Okay. So it's the secondary occlusal trauma. So it's the normal occlusal forces on the abnormal or reduced structure support. Reduced supporting structures. Okay. So you can see here the CEJ, you have some gingival recession because you have the root here. This part of the root is exposed and there's no gingiva. Okay. So this means that you end up having secondary occlusal trauma, meaning the primary problem here is that there's gingival recession. Okay, the secondary problem is going to be occlusal trauma or secondary occlusal trauma due to reduced periodontium. All right, so centric relation, as we mentioned earlier, you can actually guide the patient. You can ask the patient to relax, and you can guide the patient into CR. Okay, using a chin support or chin point guidance, and so the bilateral manipulation of the mandible conda is needed, and one of the preferred method ways of positioning the condyles in central relation is the chin point guidance. Okay. So some of these things are very self-explanatory. You just have to read them over and over and understand them. Okay. So centric relation, remember again, the position of the condyle in centric relation is in the superior anterior on the uh, in the slope of the articular eminence. Okay. All right, let's move on here. First ball. So the first balls is very important. Okay, you have to know understand the purpose of a first ball. So the first ball, they relate or they triangulate. Okay, first ball triangulates the maxillary arch to the orbitally hinge axis. So it triangulates the maxillary arch to the base of the skull. If the dentist is going to alter the vertical dimension of occlusion, it may be necessary to use kinematic faceball to record the true hinge axis. Okay, so you have different kind of hinge faceballs. Okay, so you can use the one which has a kinematic faceball. You can adjust the angles to make sure you capture a true hinge axis. Occlusal splints. So the occlusal splints, in terms of preventing or distributing forces is good, and you can protect the teeth from primary occlusal trauma or secondary occlusal trauma. Okay, so occlusal splints, they are used to help locate the centric relation. Okay, and they also help to protect teeth and supporting structures from bruxism, or just explained, and diagnosis and treatment of orofacial pain. All right. So the CR interferences, they occur on what? Okay, so this is very important. So CR interferences occur on what? They occur on the mesial incline of the upper. Okay, the mesial incline of the upper teeth. Mesial incline of upper teeth and the distal inclines of the lower teeth. That's where the CR interferences are. Make sure you remember that, okay? Or mesial inclines of upper teeth, the distal inclines of the lower teeth. All right. So the anterior teeth flaring, this can be caused due to a lot of things, but in centric relation, the mandible buccal cusp, they ramp off the mesial inclined planes of the maxillary posterior teeth, and this may contribute to flaring of the maxillary teeth. Okay, and you can have crowding. Okay, anterior dental crowding. So in centric relation, the maxillary lingual cusp, they contact the distal inclined planes of the mandibular posterior teeth, and this may contribute to crowding, to dental crowding. Okay, as you can see in the picture. All right, so let's talk about classification of occlusion. So this is angle classification. There's so many classification of occlusion, but this is Edward Angle classification. Okay. So class 1 is an ideal occlusion where you have like orthognathic profile, straight profile. This is found in 72% of patients. And then class 1 with some malocclusion, so meaning the patient is class 1 profile, but they have some dental uh, disharmony or dental crowding. Okay. So you have, and then you have class 2 malocclusion. You have class 2 division 1 and class 2 division 2. And the third class is class 3 malocclusion. Okay. Class 3 malocclusion is the rarest one, which is about 6%. The type 2, it accounts for 22%, and class 1 accounts for 72%. All right, so the key to occlusion we mentioned earlier. So the key to occlusion is knowing angle class 1 occlusion in the molars. So the relationship of the first molar to the mandibular first molar have also been called the key to occlusion. Okay. And the mesiobuccal cusp, as I mentioned in the previous lecture, with mesiobuccal cusp of the maxillary first molar opposes the mesiobuccal groove of the mandibular first molar. And this is called angle class 1. Okay. All right. So when the mesiobuccal cusp of maxillary first molar is anterior to the mesiobuccal groove of the mandibular first molar, this is called class 2. And class 2 occlusion is subdivided into two, division 1 and division 2. We're going to review division 1 and division 2. So class 2 division 1 malocclusion are characterized by excessive overjet. Okay, that's a characteristic of class 2 division 1. Okay, excessive overjet. Class 2 division 2, then you have malocclusion which are characterized by excessive overbite. Okay, class 2 division 2 is excessive overbite. Class 2 division 1 is the excessive overjet. Okay, so when the mesiobuccal cusp for the maxillary first molar is posterior to the mesiobuccal developmental groove of the mandibular first molar, the occlusion is described as class 3. Class 3 occlusion. So the lack of anterior guidance, let's see. So the following, okay. So the following patients in the images here. So this is we already mentioned this one. Let's see. So we mentioned this one, and we mentioned this one where I mentioned that this is a description of class 3, okay, on the recording. So you can see that the mesiobuccal cusp for the maxillary first molar is posterior to the mesiobuccal developmental groove. So they may give you this description and say what angle classification is it. So you have to know which one is class 1, class 2, okay? So here, In the pictures below, you can see there's lack of. These are scenarios where there's lack of anterior guidance and may be pre-considered to. They may predispose to occlusal and TMJ problems. Okay, so here you can see class 2 division 1. Okay, where there's excessive overjet, as you can see here. Some overjet there, and so there's too much horizontal overjet. And then class 3, so class 2 division 1, there's no anterior guidance. Class 3, there's no anterior guidance. And then anterior open bite, you don't have anterior guidance either. So you have to know which situations, which occlusion lacks anterior guidance. So the physiologic rest position is considered the postural position of the mandible when the head is in the upright position and the associated muscles are in the state of minimal contraction. Some of the people can call this as a natural head position of the patient, whereby you're not turning the head. Everything is relaxed, and the muscles are just in unison, and they're all relaxed. The physiologic rest position is also known as the postural resting position or clinical rest position. Okay, what is a freeway space? Okay, so a freeway space. Did I miss something here? No. So the freeway space, the distance between the occluding surfaces of the maxillary and the mandibular teeth when the mandible is in the physiologic rest. Okay, so when the mandible is in physiologic rest, and then there's some distance between the upper teeth and the lower teeth, that's called freeway space. The normal amount of freeway space, so what is the normal amount of freeway space? Is 2 to 4 millimeters. That's the normal amount of freeway space. All right, deglutition, meaning swallowing. Okay, so during the deglutition or swallowing, in the adult, the mandible is stabilized by by bringing the teeth into centric occlusion. So when you're about to swallow, the teeth go into centric occlusion. All right, and the lips are brought together in order to seal the oral cavity, and the adult usually swallows almost 600 times per day. Okay, so make sure you remember this, what happens during swallowing. Okay, all right, so bruxism and bruxism, grinding versus clenching. So grinding occurs during the night. It is generally easier to treat than clenching. Approximately 15% of the patient with grinding will continue to grind teeth no matter what we do. Clenching is, however, a daytime habit. Okay, so you have to remember that is a daytime habit of clenching. All right, so abfraction lesions. What are abfraction lesions? Abfraction lesions may be restored, and when you restore them, you have to consider adjusting occlusion on the individual tooth, because if you have so much forces here, okay, and other forces acting laterally on the tooth, so what you have is some kind of micro fractures on the CEJ, and these can lead to shelling out of the some enamel, so it leaves like a small saucer like shape of the tooth. Okay, that's an abfraction lesion. So abfraction lesion, the clinical significance is that when restoring an abfraction lesion, it is important to roughen the surface, place retention grooves, and adjust some occlusion. Yes, otherwise, if you don't do all these, it's going just to fall off. All right, so occlusal facet clinical significance. So you have to never place a splint occlusal splint margin of the preparation for cast restoration on the wear surface, and there is always a straight fume thickness of cement as we continue a cement margin. So, as wear continues, a cement margin can occur. All right. And so, occlusal plane problems, you can, for example, you can have supra eruption of the teeth. So, you have to know supra eruption. If the tooth supra erupt, what options are there to treat a supra erupted tooth? Okay. So, prior to doing any fixed bridge in 2029 and 31 in this picture, the occlusal plane on the upper arch must be restored. Okay, the occlusal plane has to be restored, and this may be necessary to do a root canal. It may be necessary to do a root canal and the crown on tooth number 3 in order to restore the occlusal plane. Okay. and so here also you can see some super eruption. So this is like a more of a clinical case. This figure here, it's like what do you do from here. So prior to restoring this patient, then you can occlusal upper has to be addressed. All right, and tooth number 2 may be in gross ear interference, and so it may be necessary to do a root canal on this tooth, tooth number 2, in order to restore the occlusal plane. So root canal and then a crown. All right. So another important one is the vertical dimension of occlusion. So vertical dimension of occlusion is considered a constant. It is a constant. And as the teeth wear, as you see in the picture, they erupt. Okay, they erupt to maintain a vertical dimension of occlusion. Now remember that the cellular cementum is constitutionally deposited to accommodate for occlusal wear, okay, of the teeth. As a general rule, one should never alter the vertical dimension of occlusion. Okay, that's as a general rule, don't change the vertical dimension of occlusion. All right, so limited movements of the mandible is caused by 1, trismus, 2, you have some interferences, and then 3, you have fibrous adhesions of the TMJ and acute disc displacement without reduction. Okay, acute disc displacement without reduction are going to cause some pain and also some limited movement. The maxillary second and third molars erupt in the buccal position, and this can cause problems too. All right, so the lateral pterygoid referred pain. So the pain to the lateral pterygoid is going to refer the pain to the cheek, to the malar region, and also to the preauricular region. Okay, So the lateral muscle is the chief source of referred pain for the TMJ area, and there's no distinction that have been drawn as to the patterns of pain referred from the two divisions of these muscles, the lateral pterygoid muscle. All right. So the deep masseter. So the masseter, you have to know that the masseter has two heads. You can see the superficial head, which is big, and then you have the deep head. Okay. So you have to keep that in mind. So the deep masseter refers pain to the ear and TMJ region, and it can be confused for, or it can so the deep masseter referred pain can be confused with TMJ dysfunction. Okay, so you have to palpate all the areas of the face. Make sure that none of them are more tender than the other ones. Okay. All right. So this is more referred pain from the SCM. So referred pain from the sternocleidomastoid can go all the way to the preauricular to the post-auricular region, and then go to the forehead and bilaterally on the forehead. Sometimes it can go to the cheek, okay, and periorbital region. So the inferior belly of the sternocleidomastoid muscle refers pain to the area of the ear, and this can be confused with the TMJ dysfunction. So I make sure you palpate the face really well. All right, so this is the anterior disc displacement. Make sure you understand it, because it's very good to understand this. Okay, so anterior disc displacement in this condition has been described as reciprocating clicking. The reason is when the mandible moves forward, it snaps against the disc, and when it goes back again, it snaps. So it sounds like a click, okay, which is called reciprocal clicking. All right, anterior disc displacement. The opening click, when somebody opens and then you hear click, can occur at any stage of the opening. It's not just during the hinge, but you can also have it in the rotation and translation movement. The closing click occurs at late closure, but it is not always audible. So you have to keep it in mind. Make sure you look at this reciprocal clicking. There's A here, and then B, what happens, and then C, and you're here at D and E. Still some the articulate disc is okay, and then here you have the disc which is a little bit anterior to the condyle, so you're going to have some clicking when you open. Okay, so this is the last slide from this one. So the anterior disc displacement without reduction. So anterior disc displacement with reduction is called clicking. Okay. All right. So this is reciprocating clicking is the anterior disc displacement with reduction, reciprocating clicking or reciprocal clicking. Now, anterior disc displacement with reduction, then this is got to be it's called closed lock, meaning it's closed and it's locked. Okay, because the condyle does not pop over the disc posterior band during opening. So in an acute closed lock of the TMJ, the mandible deviates towards the affected side, all right, on the opening front of you. So you keep that in mind. I hope this was more information which is nicely and tailored and streamlined, so you can listen to the lecture, and make sure you also view part 1 of this lecture so you can understand the basics. Okay, so we'll see you in the next lecture.